is made on the facial to roughly 2/3 the length of the tooth. I also want you to make a cut on the lingual that goes all the way across the incisal edge from the mesial to the distal. Then we need to make 2 additional cutbacks at the incisal edge. One at the mesial third and one at the distal third. Also, there's 2 little V's cut in the incisal third that define the 3 developmental lobes. Remember, these are thirds here, and you have to make the cut all the way from the incisal edge to the middle third. These cuts go all the way through the incisal, notching the incisal edge, and taper off up to the middle third. Once all of these cuts have been made, replace the dentin porcelain by first applying very translucent porcelain known as T-powder inside the V-cuts. T-powder, or translucency, makes the V-cuts more visible and increases translucency. Next, build up to 7.5% over the desired final contour using enamel porcelain. And as you add, make sure the enamel porcelain comes down over the front of the body porcelain, blending it all the way to the gingiva. Make sure you cover the mesial and distal cutbacks with enamel porcelain as well, wrapping it around the edges of the dentin. This will produce a much more natural appearance. Why do we make these cuts and then reapply porcelain? It's all about creating natural-looking teeth without relying on a big wheel grinding after the bake. Grinding teeth out of overbuilt bakes wastes porcelain, your time, and makes it difficult to create natural-looking teeth with the translucent areas where they belong. In natural dentition, there is a translucent enamel that allows light to show through the incisal edge from mesial to distal. You can see the developmental lobes because they're defined by adjacent areas of translucency. That's why we make the room for the enamel porcelain, so that your restorations will show this depth and vitality. That's one of the ways we get away from the blocky, monochromatic look. I also want you to make a concave angled cut on the lingual that goes all the way across the incisal edge from the mesial to the distal. Use T-powder to replace the material you just removed. This will give you more translucency. It will also create a little milky white opaque edge on the incisal edge when finished, a feature seen in natural teeth that is called the halo. T-powder should always be a part of your porcelain tray. By using a third powder, a translucent porcelain in your buildup, the outcome can be absolutely outstanding, and it takes very little time to complete. Just take a look at the difference between these 2 centrals. These build-up techniques are quick to do and can be easily completed using a spatula. I've always preferred using a spatula instead of a brush for build-up because spatulas are much more time effective. You cannot pack things quickly with a brush because you have to work very wet and everything melds together and your build-up can easily collapse. As a result, you lose that natural look. You lose the anatomical features you built in. Plus, you spend a whole lot of time packing with a brush. You never see brush packers that are fast. They're always slow and the process is labor-intensive. Even if they take the time to build them up with a brush, they still have to come back and cut back with an instrument. Then they start throwing wet porcelain onto wet porcelain, and that makes it very difficult to work. Just try to condense a wet buildup. It can be done, but it's technically more difficult to accomplish without the porcelain slumping. You want to build up your porcelain as dry as possible. It's already pre-condensed just sitting on the tray. You can pound on it, but the porcelain is packed and condensed already. You can't condense porcelain more than it condenses just by sitting there on the tray. When you fire it, you get your payoff, because as you will find, there's a lot less shrinkage and tearing when you use condensed porcelain. Once the bake is cooled, you want to get the restoration to seat correctly on the model. After that, you're going to establish your rising line of contacts. You must also grind in the emergence profile and then correct the incisal lengths of the teeth so that they are both aesthetically pleasing and functionally accurate. You may even need to touch up your primary contouring as well and possibly do another bake. Next, you're going to add all of the natural anatomical features that make anterior dental restorations look like real teeth. I'm talking about facial anatomy. That is, the features that are visible on the facial aspect of all anterior teeth. You're going to grind in 5 slight depressions on the facial surface to help break up the light so we don't have flat surface reflections coming out of the front of the mouth. I'm not using a number 37 carbide here. I think the easiest way to grind is to use a big stone. I prefer a used stone because the edges are rounded and I want smooth grooves. You know, very light depressions, not really cuts. These are big stones and you use just a little bit of pressure to create slight depressions in the surface of the tooth. Keep in mind, you're not building up or adding material, but rather removing small portions of baked porcelain. Now, an anterior tooth is made from 4 developmental lobes that fuse together. 1 lingual lobe called the cingulum, and 3 on the facial, called the mesiofacial, the centrofacial, and the distal facial lobes. In this case, we're looking at the upper centrals. The highest spots in the facial aspect of anteriors are these developmental lobes that are created during the buildup. The most dominant is the mesiofacial lobe, which starts at the mesial incisal edge and moves towards the gingival and shoots away from the midline. There's another shorter lobe at the distal facial lobe, and an even smaller lobe located in the middle of the incisal third called the centrofacial lobe. There are 2 developmental grooves on the incisal 1/3 that separate the 3 facial developmental lobes. 1 at the mesiolabial developmental groove, and 1 at the distolabial developmental groove. These grooves appear as low areas with increased translucency and are perpendicular to the incisal edge. It takes just a very light touch to grind these 2 developmental grooves into the tooth surface. Developmental lobes and developmental grooves are present from the very early stages of an anterior tooth development and contribute greatly to the visible contours of the tooth. There are other depressions on our natural tooth example as well. For example, at the lower end of the middle 1/3, there is a slight depression, and it is perpendicular to the long axis of the tooth, connecting the 2 developmental grooves. There are 2 more slight horizontal depressions located in the middle and gingival thirds of the central incisor. All 3 of these very slight depressions can be created with just a little effort using a big stone wheel. By grinding in these 3 slight depressions, 2 slight elevations are created between them, one in the middle of the tooth and the other at the gingival third. These elevations are less pronounced than the developmental lobes we've already talked about. By grinding in just 5 depressions, you've created 10 anatomical features on the facial surface of an upper central. The dentist won't even know what it was that you did, but he'll tell you that is one good-looking tooth. The great thing is you can make all of your anterior teeth look great by adding varying degrees of surface anatomy in this manner. Get some denture teeth out. Study some of the really well-done ones, such as Dentsupply's portrait teeth. You'll see all the anatomical features we just talked about. Keep in mind, even on real teeth, these irregular surface features are very subtle. But by breaking up and dispersing the light across the surface of the tooth, they make the tooth aesthetically pleasing. Now, I think it would be a big mistake to talk about anterior surface anatomy and only discuss the features found on the facial aspect. We have to talk about lingual anatomy too. The features on the lingual aspect include the lingual fossa, the mesial and distal ridges, the lingual portion of the incisal edge, the cingulum, and on the upper centrals, the tubercles. Lingual anatomy is extremely important for a variety of functional reasons. First, it helps deflect food, protecting the gum tissue and providing the proper amount of stimulation to the gums. Second, it redirects food for continued mastication. Third, it provides landmarks that the tongue memorizes and seeks out in order to form words. Lastly, it provides contacts to the opposing teeth for protrusive guidance. We know that dentists try to leave as much tooth structure as possible when they prepare teeth, but often there is not enough interocclusal space available and the addition of lingual anatomy is not really possible. You can't do anything about that except maybe create a metalingual. However, under good conditions, we grind in the lingual fossa with a tapered stone. When we do that, we want to leave higher areas of porcelain that will become the mesial and distal ridges, the incisal edge and the cingulum. To define the cingulum, which is a fairly pronounced feature on the lingual aspect of all anterior teeth, use a tapered stone to grind in a concave area from the incisal edge to the middle third. The cingulum should rise sharply at the cervical third and remain prominent all the way to the CEJ. Make sure you visualize the correct emergence profile as you define the cingulum. Also keep in mind that on upper anteriors, the transition from the cingulum to the fossa has a profile that we refer to as being shovel-shaped, whereas lowers are straighter and are considered chisel-shaped. Once the cingulum has been defined, round off the mesial and distal aspects within the lingual fossa. Remember, on lower anteriors, the mesial and distal ridges are much less prominent than on the upper anteriors. On upper centrals, there are two tubercles coming out of the upper part of the cingulum, fading into the lingual fossa. Tubercles are finger-like projections of enamel and can be easily created by slightly grinding the surrounding surfaces using a carbide burr. Glide your tongue along the lingual aspect of your anteriors so you can understand the subtle dimensions of these lingual anatomical features. Understanding your own anatomy should help prevent you from creating lingual anatomy with features that are too pronounced. Now, depending on the dentist's requested design, your incisal edge will be based on the patient's age, bite classification, and sometimes the patient's habits. So, for example, if you have a real young patient, we know that the dentin is completely covered with translucent enamel and the incisal edges will show mamelons. Mamelons appear as protuberances on the incisal edge of newly erupted incisors. Mamelons can be easily created by grinding in the labial developmental grooves to the point where the incisal edge becomes scalloped. By grinding in the grooves in this manner, the incisal portion of the developmental lobes become the mamelons. And now the crown looks like a tooth from a young person's mouth. As time goes by, the mamelons wear down because of anterior incisal contact during protrusive movements and generally disappear once you've reached your early 20s. On older patients or bruxers, the incisal edges tend to get completely squared off, and not only has the edge gotten square, it's gotten shorter. The enamel wears down, eventually exposing the dentin. Over time, the softer porous dentin erodes away, leaving a groove that is surrounded by a wall of harder, translucent enamel. This is called an incisal depression. This depression is easy to spot on dental stone models and can be a clue as to the age of the patient and the condition of the patient's teeth. Squaring off the incisal edge with a big stone wheel can easily create the look of a worn incisal edge. The more of the incisal edge you remove, the older the restoration will appear. So you want to be sure you're matching models or photos of the patient. Then, using a small tapered stone, grind in the groove with a squared off incisal edge. Keep in mind, the deeper the groove, the older or more worn the tooth will appear. Now let's talk a little bit about abraded anterior occlusal contact surfaces. I'm talking about the palatal surfaces on the upper anteriors and the incisal edges on both upper and lower anteriors. These opposing surfaces continually come in contact with each other while chewing, and of course, will show wear sooner than other surfaces. The abrasion actually flattens the surface and makes it shinier. After the staining bake is done, you can reproduce these features using a white rubber wheel to smooth the contact surfaces. Then you can follow up with a pink, high-shine silicone wheel to polish the contact surfaces to a high gloss. Polish the occlusal contact areas and you'll be adding realism to your restorations. I'd like to talk next about pericymata, a feature of the enamel that brings to mind the yearly growth rings in a tree. During permanent tooth development, enamel crystals grow subgingivally in little horizontal waves at a rate of about 4 microns per day. After more than 3 years of this subgingival growth, the enamel structure of the tooth is complete. Then around the age of 7, the permanent central incisors start poking through the gum tissue. Very faint horizontal lines, about 30 to 40 microns apart, can be seen on the labial surfaces. These faint horizontal lines are called pericymata, and each line represents about 7 days of enamel formation. A fully developed central has about 165 of these pericymata, and the first 30 or 40 start at the incisal edge. Young people up to 20 years of age have really pronounced pericymata, and when you combine that with clearly defined developmental grooves, the overall effect is to make the surface of young people's teeth rough, not smooth. After years and years of chewing food and brushing teeth, the pericymata tend to smooth out and become less pronounced. Ultimately, only a very few of the most prominent pericymata will remain. Glide your tongue along the facial aspect of your anteriors. You can easily determine the state of your own pericymata. If you're real young, I can guarantee you're going to feel that roughness. If you're older, it's going to be pretty smooth. Pericymata don't wear at the same rate over the surface of the tooth. That is, the pericymata in the high areas will be smoothed off, but the pericymata in the grooves and depressions won't. Also, pericymata tend to wear off sooner in the incisal third than they do in the middle and gingival thirds of the tooth. When you smile, the smooth areas are going to reflect more light than the grooves and depressions do, creating tooth surfaces with varying reflectivity. So just as natural dentition is not arranged perfectly straight like a picket fence, natural teeth aren't perfectly shiny and smooth like a strand of flawless pearls. Over time, the surfaces of all natural teeth will show differences in reflectivity because of the way they wear. For older patients in their 60s, 70s, or 80s, I wouldn't add pericymata at all because their natural teeth will be pretty smooth by then. For a young patient, say up to 30 years of age, maybe he's an A1 or B1, you want to be sure to put in some pericymata. For everything in between, you have a transitional stage where some portions of the pericymata remain. For example, you'll have a slight depression here with a little pericymata that gives it a little surface texture. On the high areas around it, the pericymata will be smoothed off somewhat. As a result, they're going to reflect light differently than the low areas do, and that's what you want. Since the dentist rarely tells you the age of the patient, you can base the pericymata on the shade. If it's an A1, A2, or D2, you know you're not dealing with someone in the twilight of his or her years. These patients are young enough that you should add pericymata to the restorations. Use an older, small tapered diamond burr that doesn't cut as readily as a brand new one. I insist that you use an old one. If you only have a brand new burr to use, you need to dull it off first on a truing stone to reduce its cutting power. Then to use the burr, roll it horizontally across the surface of the tooth, using very little pressure. By repeating this motion multiple times as you move down the facial, you will give the grooves a slightly rolling appearance. Periodically, you can wet the porcelain surface to see whether you have achieved the desired results. Additionally, some teeth have slight ridges on the cervical third. These ridges extend mesiodistally just like pericymata, but are much more pronounced. These are called imbrication lines. Use a slightly larger burr or even a tapered stone when creating imbrication lines. Imbrication lines should be added when adjacent teeth have them, or in cases where you must visually shorten a tooth without grinding in the CEJ. Keep in mind, you will be grinding in low areas, and in the process, the ridges of the imbrication lines will emerge. Now, I want to talk about staining and glazing. The kinds of characterizations we do in the lab are pretty simple and take very little time to do. As technicians, you'll find that instead of using 10 different porcelain powders for the buildup, stains are great tools for individualizing ceramic teeth. Now, there are good things and bad things about stains. The good thing is stains cover things up. The bad thing is stains cover things up. What I mean by that is you can use stain to improve a restoration. For example, concealing areas where dentin is thin and a shade correction is needed. On the other hand, too much stain in the incisal area can cover up the translucency that gives the tooth its vitality. Stain the interproximal so the teeth appear more separated. and stain the gingival to more closely match the shade on the prescription. And when you use stains, remember this staining rule. Always use the shade tab to check your color before you do your final glazing bake. You'd be surprised how much this adds to the natural look of the teeth you just created. And it does that by enhancing the contours. Now, let's look at some natural dentition again. In a lot of people's mouths, there's real translucent enamel on the incisal, and there's usually a little white opacity through here around the incisal edge called the halo effect. The halo is a reflection of light coming from the edge of the roughened incisal surface of the enamel. This reflection turns the translucent enamel edge into a milky white line that is visible at any age as long as there's enamel left. To enhance this feature on your restorations, you can apply a little bit of white stain with a small brush right on the incisal edge. That little addition will make the halo more visible and the translucent incisal will look more realistic. As we've already discussed, when the patient has worn through the enamel on the incisal edges of the upper and lower anteriors, an incisal depression of exposed dentin is created. The yellowish and exposed dentin is porous and therefore easily stained by bacteria as well as coffee, tea, and tobacco, causing a browning effect. The minute you see that the dentin has been eroded, put some ochre stain along the incisal edges. You almost need to flood the whole area where the dentin is visible. Leave a little bit of translucency around the incisal edges to retain some of the tooth's original vitality. Technicians with a great deal of experience can put the stain on the body buildup underneath the incisal edge to create an even more natural look. My point being, this is age 20, here's age 40, and here's age 60. By the time you're 75, you have just a little translucency left, and realistically, you have all this area here permeated with stain. I can guarantee you, if you get an 80-year-old patient who's an A4, you have a whole lot of incisal staining along here. If the patient is an A1, you never want to add incisal staining. Also, you don't want to put a perfectly white tooth next to a tooth that has an eroded dental area because you know they won't match. The apparently intact enamel of canines' incisors often has pre-existing vertical cracks known as enamel lamellae. These are caused by imperfect calcification of enamel during tooth development and may extend all the way through the enamel and into the dentin. Lamellae are not normally visible unless, say, the dentist shines a bright light through the tooth. These cracks become stained over time, making the lamellae visible without a backlight. And as we get older, these crack lines get darker but remain ultra thin. Similar cracks are found on the buccal and lingual surfaces of molars and premolars. You can create these stained lamellae on your restorations, but only if the dentist has indicated where they should be placed. Using a thin staining brush, apply dark brown stain using a quick vertical movement from the incisal towards the gingival. If the line turns out to be too thick, then wipe away one side of it with a clean brush. In addition, a vertical streak of white stain on either side of the brown line increases the illusion of depth. When it's finished, the lamella should be thin, straight, and well-defined, resembling a hairline. Not all aesthetic issues involve the presence of dark stains on teeth. For example, both decalcification and dental fluorosis are visible as white anomalies at or below the surface of existing natural dentition. Decalcification results when calcium salts are lost from the enamel. This can be caused by a dietary deficiency in calcium or because an acidic condition persists in the oral cavity. Dental fluorosis is a result of a high systemic fluoride intake prior to the eruption of permanent teeth. In severe cases, this will result in a failure of the enamel to crystallize properly, causing surface defects in the enamel. These anomalies in the enamel can show up as spots at the incisal, a soft mottling all over the incisal, a white band around the middle third, or a chalky opaque blotching all over the labial surface. Refer to patient photos or the dentist's instructions on the RX to determine the correct placement and amount of these surface discolorations. You can make these features with a staining brush using white stain. In some cases, the extent of the discoloration can be extreme, with colors ranging from white and yellow to brown and black, though we rarely see extreme cases like this in the lab. For teeth with tetracycline stains, the dentists rarely include patient photos and will simply tell the lab that the patient's teeth have tetracycline stains. That's because the dentist expects you to be the expert in this. So what is a tetracycline stain? Tetracycline is a common antibiotic, but when taken while the teeth are developing, for example during infancy and early childhood, the teeth become permanently discolored. It is the developing portion of the tooth that is affected, typically causing stains in horizontal bands. In mild cases, tetracycline stains are a yellow-orange band encircling the middle of the tooth and are combined with a blue incisal. In the most severe cases, the middle band is orange-brown and combined with a dark blue-gray incisal. A No. 1 glazing brush with a little bit wider tip than a staining brush is a real good tool to use if you're going to reproduce tetracycline stains. I'd like you to get used to trying this sort of characterization so that if you come across a case like this, you know how to proceed. Once all of the staining is complete, you'll put your restoration in the oven and bake it. Because the staining bake provides enough heat to end up with the surface you want, this will be your final bake if you do these two things. 1. Use a spatula to pack the porcelain. That's a ceramic buildup technique I've used for over 30 years. By using a spatula to pack porcelain, the fired ceramic will not be porous. And number 2, use the correct firing temperatures for your staining bake. If the temperature is right, the final result will be a glossy surface, and that is the glaze you see on the shade tab. So by following these two simple steps, you won't need to fill in the surface with a glaze or do any extra glazing bake. It's as simple as that. Take your shade tab and look at it. That's your standard glaze for your posteriors. Without this standard, 14 technicians will come up with 14 different concepts of what a glaze should look like. So you shouldn't accept a surface glaze on a posterior that's less than a shade guide glaze. The reality is, use 2 separate glazes, one for posteriors and slightly less of a glaze for anteriors. If you're trying to maintain the look of the perichomata on younger people, say up to 30 years of age, that too will be a lower glaze than the posteriors. In general, if you are unable to achieve the brilliance desired in your glaze, you may need to add glazing powder to your staining liquid before you apply the stain. Glazing powder is just one more tool in your Ceramus arsenal, but it should only be used if it enhances the overall appearance of your anterior restorations. Have you ever heard of polishing ceramic teeth after the staining bake? Polishing is the final step that will help make your restorations look more realistic. But in this case, we are not making the surfaces shinier, we are changing the high gloss staining bake finish of the prominent contours into a matte finish, and furthermore, we may be wearing down the most prominent contours. And why would we do that? Just look at some older teeth. They're not really highly glazed, are they? They are more of a matte finish and have a softer patina to them than the porcelain teeth we glaze. Now when I talk about patina, I'm referring to the gentle, natural wear patterns of aging that gives older surfaces a rich and attractive appearance. So, to age a restoration and make it look more realistic, we're going to polish the surface features that stand out above the rest. These include the developmental lobes, embrocation lines, and of course the perichomata, which add texture to the surface. We want to polish these areas first because in real life they would be worn down sooner than the other, less prominent features. Now, the basic rule of thumb regarding polishing is this: make smoother textures on teeth for older people, keep rougher textures for younger people. It's obvious, even to the untrained eye, that the surface of a young tooth has a glossy and gritty look to it. It's not smooth. So when you're trying to achieve a real youthful appearance, like teenagers have, you don't want to polish the teeth at all. On the other hand, when we create a restoration for a 20 to 40-year-old patient, the surface will be duller and smoother with less visible perichomata than young dentition. If the restoration is for somebody from say 50 to 80 years old, the surface will be even smoother with little or no visible perichomata. To polish teeth, I'm talking about taking a pink rubber wheel after the surface is glazed, spinning the wheel slowly, and applying just a slight amount of pressure to dull the high areas. Remember, when we polish, we're also removing puricomata from the high areas, making the tooth smoother. Now you need to be real careful not to grind off all that staining characterization that was just added. You know, the halo, lamellae, and decalcification. In cases like these, with a lot of staining characterization, make sure you knock down the high areas by polishing with a white rubber wheel before you stain and glaze. Then later, it will take only a slight stroke of the pink rubber wheel to dull the glaze without removing the stained features. By following these polishing procedures, you're going to end up with nice looking restorations with some beautiful surface reflections, just what we see in natural dentition. Now this concludes our coverage of anteriors. Up next, we're going to talk about posteriors. Welcome to this exciting section about posterior teeth. Over 70% of the restorations performed by dental laboratories are for posterior teeth. Because of that, this segment is the most important segment you will ever view. In this section, we'll cover health of the oral cavity, basic posterior setups, occlusal surfaces, contouring, staining, glazing, and finishing. One of the ways to learn about posteriors is to draw them. In fact, I would encourage all technicians to learn how to draw every tooth in the mouth. Drawing helps you to recognize and memorize subtle changes in contour. It will also help you to understand the proportional relationships that exist between anatomical features. Then, when you're reworking at the bench, you will be able to recall these features and relationships, enabling you to better visualize your final restoration. This will make you a much better technician. By now, you have viewed the first two segments of this video, whole arch anatomy and anteriors. Now we're going to concentrate on posteriors. It's nearly impossible to talk about the posterior teeth without occasionally referring to the anteriors. So don't be too surprised to hear me refer back to topics covered in the previous sections. And of course, there'll be many new topics covered, such as occlusal ratios, stamp and shear cusps, contouring, contact areas, contact circles, the occlusal table, occlusal surfaces, and tripodized occlusion. In the anterior segment, you learned how aesthetic concerns often compete head-to-head with function when designing anterior dental restorations. Posteriors, on the other hand, have been traditionally designed to address functional concerns rather than aesthetics. Function is so important to the patient's oral health that it's an integral part of my stylized anatomy. I developed this stylized anatomy years ago so you can create functioning teeth with repeatable and consistent quality. I talked about it in my original chalkboard presentation, and I will talk about it here. After all, it's a system that really works. These days, however, it's getting harder and harder to create posteriors based solely on functional concerns. That's because patients are becoming aware that along with their anterior teeth, posterior teeth are also visible when they smile. This is especially true for the buccal surfaces of uppers. What they are looking at is what we call the buccal corridor, a transitional area that includes the canines, the first and second bicuspids, and in some cases, the first molars. You should always strive to make a visually smooth transition from the anteriors to the posteriors within the buccal corridor, just as long as you do not compromise function. Now, before we get too deep into the discussion of posterior teeth, I want to take some time to explain periodontal health and how it relies on function that you build into your restorations. You may recall that in the anterior section of this video, we covered the structure of the tooth as it relates to translucency and shading, as well as the relationship between unhealthy tissue and compromised aesthetics. Well, now I want to discuss tooth and tissue structure as they relate to the health of the patient's oral cavity. What I want you to understand is how your crowns affect the health of the alveolar bone and the hard and soft tissues, that is, the tooth and the periodontium. You should know that the leading cause of tooth loss is periodontal disease, not tooth decay. And a bad crown can be the start of periodontal disease. For a tooth to remain healthy, it needs to be fed, and it gets its nutrients from the blood that is being pumped through the root canal system. Originating at the apical foramen, vessels within the root canal system connect the pulp chamber to the bloodstream. The pulp within this chamber is the tooth's main source of nourishment. It not only contains blood vessels and nerves, but also other tissues such as lymphatic vessels, fibroblasts, and collagen fibers. The pulp chamber is surrounded by dentin, which forms the largest portion of the tooth. Dentin is a porous material that, when ground with a handpiece, makes a noticeably different sound than the much harder enamel. The area coronal to the cemento-enamel junction, or CEJ, is the anatomical crown. Here, the dentin is covered with enamel, the hardest and smoothest portion of the tooth. Apical to the CEJ, the dentin is covered with cementum, a bone-like material that covers the entire root surface. Cementum is not as dense or as hard as enamel or dentin, and in cases of gingival recession is more likely to decay than enamel. Within the dentin and the cementum are microscopic channels called tubules. In the case of the dentin, these tubules run from the pulp to the junction of the dentin and enamel, and from the pulp to the junction of the dentin and cementum. In the cementum, tubules run from the dentin to an outer layer of soft tissue called the periodontal ligament. Tubules are filled with fluids that are sensitive to change in pressure. These changes can occur in several ways. For example, when hot or cold food or liquid is consumed, the dentinal tubule fluids expand and contract with the temperature changes. This causes sensitivity at the pulp that the brain interprets as pain. Bacteria can also cause pain in the oral cavity. This occurs when bacteria metabolize sugars, creating lactic acid. With continued exposure, the lactic acid will demineralize and destroy the tooth structure. This could lead to infection and subsequent death of the pulp, ultimately leading to tooth loss. So what is it that technicians do